Great. Good morning. Thank you for joining us for the Sexual Health Best Practices for Breast Cancer Patients live stream. If you have any questions for our speaker today, please enter those in the Q&A section at the bottom of your screen. Excuse me. We have approximately 10 minutes to address those following Dr. Agarwal's presentation. Participants will receive a link following the program for an evaluation. Please fill that out. You can also use the QR code that will be displayed following the live stream today, or the link that will be provided at the end of this program in the chat box. This program will be available online within a week or so at the nortoncme.com. Now let's take a few moments to do an audience poll so we can better understand our audience. Please click the answer that best relates to you. So you can see here, 28% say yes, 26% no, and 46% say not applicable. Question number 2. Are you comfortable addressing sexual health with your patients? Please fill out your questionnaire. In post-conference, you'll get this. Did this program increase your comfort level with discussing sexual health with your breast cancer patients? Okay, so let's move on. And it's a real pleasure for me to introduce our speaker today, Dr. Leila Agarwal. She earned her medical degree from Indiana University School of Medicine in Indianapolis. She completed her residency at Washington University School of Medicine, St. Louis, Missouri, and her fellowship in hematology and oncology at Vanderbilt University Medical Center, Nashville, Tennessee. Dr. Agarwal focuses on breast cancer treatment and general oncology. She has several publications and conducted extensive research on managing and treating metastatic breast cancer. Dr. Agarwal has no relevant financial relationships to disclose. I will say that personally, I think Dr. Agarwal is a doctor's doctor. She's an absolutely incredible clinician, compassionate, and I think you'll find from this talk today is really working to ensure that we give the best care to our patients. So welcome, Dr. Agarwal.
Thank you so much. So let me see. All right, so I'm sharing my screen. Has that come up now? Okay.
Yes.
Wonderful. All right, well, thank you so much. I'm so thrilled to be giving this talk on what is such an important topic. So I'll be talking about sexual health best practices for breast cancer patients, but the information I'm going to go over today will be relevant for female sexual health for many different cancer types as well. Here are my disclosures. So to start off with, let's talk about sex and cancer. So why is this important? According to the World Health Organization, sexual health is fundamental to overall health and well-being of individuals, couples, and families. And this is important not only in the reproductive years, but throughout an individual's lifespan. So I think it's important to start with this point, which clearly establishes that sexual health is an important medical issue and is important to patients' overall health and well-being. So how does cancer affect this? So cancer and cancer treatment can negatively impact sexual health in many ways and through many different treatments. So surgery, chemotherapy, radiation, and hormone blockers are all treatments that you can imagine how these impact sexual health. But other things as well, like stem cell transplant, can cause graft versus host disease in the vagina, which can also impact sexual health. So when we're thinking about sexual health and sexual dysfunction, a very good way to think about this is in the context of a biopsychosocial model. So in this model, multiple different domains come together to affect somebody's sexual function. And these are biological factors, but also psychological, interpersonal, and cultural factors that come together. So this is really called the biopsychosocial model. So under the biology, hormonal changes that result from estrogen reduction, anatomical changes such as vaginal atrophy or stenosis can happen. This can happen as an effect of surgery, for example, for gynecological malignancies, or from estrogen reduction. Loss of a body part. So after breast surgery, loss of the breasts, loss of sensation. So, many patients are reconciled to the loss of the breast with the mastectomy, but may really miss the effect that the sensation of the breast and the nipple had on sexual function. Pain and fatigue can be a part of sequelae from cancer treatment as well. And so there's medical interventions that can be done to address these biological changes. On the psychological side, going through cancer and cancer treatment can certainly cause mental health disruption, so anxiety, depression, and in addition, the way that patients think about their body image through cognition and negative thinking can happen as well. And it can also, let me jumping ahead here, can also affect motivation. And so treatment here involves counseling or even cognitive behavioral therapy. In the interpersonal domain, relationship problems can come about. I mean, we've all seen it before where a relationship that has problems before cancer is typically not going to get better through a cancer treatment and diagnosis. Lack of communication and fear of intimacy can happen as well. And then in the cultural domain, clearly religious beliefs, cultural values, and social norms all play a big role on how individuals perceive sexual functioning and their own sexual efficacy as well. So one of the items that I mentioned under biological changes are symptoms of low estrogen. So for breast cancer patients and for other cancer patients, symptoms of low estrogen can come about because chemotherapy may induce an early menopause, or hormone blockers, for example, for estrogen positive breast cancer, can cause symptoms of low estrogen. And in terms of sexual functioning, this has many different impacts, including low libido, bladder infections, joint aches, night sweats, mood changes like anxiety or depression, insomnia, pain with sex, mood swings, not to mention infertility, and then certainly vaginal dryness. So many of these symptoms of low estrogen really cause sexual health concerns for our patients. So I've invited my friend Audrey Hepburn, wearing her beautiful pearls, to share some clinical pearls with us throughout this talk. So here she is to say, treatment-related sexual health dysfunction is one of the most prevalent and distressing side effects of cancer treatment. And to understand that prevalence, long-term sexual health problems have been reported in 50% of breast cancer patients, in 65 to 90% of gynecologic cancer patients. And while it may not be the first type of cancer that we think of, female patients with colorectal cancer, approximately 60% may have long-term sexual health problems. And when we're looking at one particular sexual health problem, which is pain with sex, 45% of breast cancer survivors have reported to have pain with sex, and 55% of patients with gynecological cancer or rectal cancer have pain with sex. So how do these numbers compare to a population who doesn't have cancer? So this is a study that looked at prevalence of female sexual dysfunction in a non-cancer population. And the important thing here that I want to highlight is that there can be a sexual problem, but if it causes distress to the patient, that's really when we need to make sure that we're addressing and intervening appropriately. So a recent study that was just reported in 2020 took a survey of over 400 cancer patients, the majority were female, and surveyed them regarding impact of cancer on their sexual health. And this survey reported that 87% of these patients said that cancer treatment impacted sexual function or desire. 73% reported dyspareunia or pain with sex. 53% had body image distortion, 42% were unable to achieve orgasm. And although those numbers are very high, only 28% had actually formally been asked by a medical provider about sexual health. And that number, 28%, is actually even a little higher than other studies that have reported the same question in the literature. In addition, there was a gender disparity among who was asked about sexual health. So female patients were less likely to have been asked about sexual health than male patients, 53% versus 22%. And why does it matter? What is the impact of sexual dysfunction? So sexual health has been reported by cancer survivors to be the third most common concern. And sexual dysfunction can be associated with distress, poor quality of life, and mood disorders. So here, hopefully, we've established that sexual health is a medical issue important to quality of life, and that it is very prevalent, very common among cancer patients. So the next point, let's see, Audrey's back, and she's here to tell us another clinical pearl, that sexual health problems caused by cancer treatment do not magically disappear. And I want to highlight that point because as I started to learn and understand more about sexual health care for cancer patients, and really made it a point to ask all of my patients about this, I started to learn more and more from my patients. And I had one patient who had been diagnosed with cancer 30, 40 years prior, and then had a second occurrence of cancer. And when I was asking her about her sexual health, she told me that she developed sexual dysfunction after her initial cancer diagnosis 30 to 40 years ago that never got better. And she also said that I was the first person who had ever asked her about this. So I think the importance here is, unlike some other problems such as fatigue, which could get better with time after cancer treatment, sexual health problems do not get better on their own. They need to be assessed, addressed, and interventions offered. There are many barriers to providing care in this domain, and studies have shown that on the part of patients, there may be a concern about making the doctor feel uncomfortable. There may be some embarrassment, and that comes from, in the biopsychosocial model, the social and cultural factors that are put onto sex and sexual health. But I would highlight also that one of the barriers is that patients have expressed a belief that it's the doctor's responsibility or the medical team's responsibility to raise the issue, and I would agree with that. And then some may feel that sexual health concerns are not valid or are not treatable, and that's just a consequence of having cancer that they just have to live with. And we want to really work together to address that and make sure that that's not the case. On the side of medical professionals, there can be a feeling of being insufficiently trained or skilled. And I certainly can, attest to that in formal medical training, talking and learning about sexual health is not a big part, or for many people, not a part at all of medical training. And that might lead to discomfort. We also have time pressures. We have a lot of, demands on our time with the patient, covering a lot of important issues in a short period of time. But also there may be limited awareness about the interventions that can be offered. And certainly it's hard to, ask a patient about something if you don't have anything to offer to help as a medical provider. Some may have concerns about making patients feel uncomfortable, or there may be some assumptions that are made. And then limited availability of specialty services for sexual health. So some of the common misconceptions: patients will tell you if they have sexual health concerns. That's not true. Some studies have shown that only 3% of patients who have sexual health concerns may actually bring them up spontaneously. Unmarried or unpartnered patients don't have concerns. Older patients don't care about sex. Patients with metastatic cancer are too sick to have sex, or only breast and gynecological cancer patients could have treatment-related sexual health changes. So for this one, I brought the queen herself to say, no, those are all misconceptions. They're not true. And we have to kind of evaluate our own thoughts that we bring into the exam room to understand if we have some of those misconceptions. So hopefully at this point, you're all super excited, just like me, to address sexual health care for cancer patients and to be able to move forward and improve this. So we're not the only ones, because ASCO, the American Society of Clinical Oncology, has put out a series of guidelines and recommendations for how to assess and how to manage sexual problems in people with cancer. And this is adapted from guidelines that were put out by Cancer Care Ontario. So the very first recommendation is that there be a discussion with the patient initiated by a member of the healthcare team about sexual health and sexual dysfunction. So Audrey's here to share the pearl that the recommendations that follow can only be used if somebody has taken the initiative to ask. So that is really, if you don't take anything else out of this talk today, please understand the importance of asking, of the medical provider asking about sexual health. So how do we do this? How do I assess sexual health in the clinic? So in the next few slides, I'm going to go over different ways, different strategies to assess sexual health in the clinic. And I would challenge you all, when you go back to your clinics this afternoon, to try some of these different techniques and see which one works best for you and your workflow in order to be able to consistently and routinely assess sexual health. So the most straightforward way is just ask. So this may sound like, do you have any concerns about your sexual health, such as interest in sex, vaginal dryness, or pain with sex? Another way is to give a ubiquity statement. And by saying of just a very general blanket statement, it legitimizes and normalizes sexual health as something that can and should be discussed in a medical visit. So for example, many patients with breast cancer have changes in their sexual health. Do you have any concerns? Oftentimes when I ask this exact question to my patients, they'll say, no, I don't have any concerns. It's important to follow up with specific questions. For example, do you have any vaginal dryness? Do you have any pain with sex? Or do you have decreased libido? So to a patient who may have said that she didn't have any concerns, may then follow up by saying, oh yeah, I have really bad vaginal dryness and it hurts to have sex. In fact, I don't even have sex anymore because it hurts so much. And so that's the importance of following up the ubiquity statement and the general question with specific questions. Another strategy is to ask in the context of a patient's relationship. And this may work well for a new patient or a patient who you're meeting for the first time. Are you in a relationship? If so, are you sexually active? Do you have any concerns? And if not, you ask about concerns that may have caused you not to be sexually active. And another way is through just a basic assessment of sexual function. So just like we assess multiple different systems in our everyday clinic visits, like are you having trouble breathing? Are you having nausea, vomiting, or diarrhea? To put sexual functioning in that same context immediately legitimizes it as a medical concern and just a very normal thing to be asking a patient. So a little more detail about screening for sexual function is to legitimize the sexual function. So just a statement from the medical provider that says, this is an important issue. So oftentimes after cancer or cancer treatment, there can be changes in somebody's sexual function. Are you currently involved in a sexual relationship? If yes, then you can start asking about any sexual concerns there. If no, it's not necessarily the end of the story, because you want to ask, is there a reason that you're not in a sexual relationship? And this is where you might find out that, well, I bleed every time I have sex and it hurts so much that, my husband doesn't want to hurt me. And that's when you really find out the extent of this problem. So even when you have the ubiquity statement and you have the question about the relationship, you still follow with specific questions. Another way is this model called the Plicit model. And this is something that's been around since the 70s to assess sexual function. And it starts out with first giving permission to the patients to raise the issue, then providing limited information, followed by specific suggestions for that problem. And then if needed, moving on to more intensive therapy. So one example from the cancer clinic would be first giving permission. Sexual concerns are really common among breast cancer patients. Are you having any concerns? They might say no. Then you can provide limited information. For example, aromatase inhibitors frequently can cause vaginal dryness. The patient might say, oh yeah, well, I do have that. and then follow with specific suggestions. Using vaginal moisturizers regularly and lubricants for intercourse can help with that symptom. And then if needed, refer on for intensive therapy. If that doesn't help, I'd like you to see your gynecologist. Another strategy is something that has been developed and published for assessing sexual health for cancer patients, and this is the checklist. So this is available, and if it works in your clinic, you can actually use this checklist for patients to fill out and assess themselves. So it starts off by asking, are you satisfied with your sexual function? Yes or no. And then it goes on, importantly, to ask, do you have any concerns about vaginal health? So even a person who is not in a sexual relationship may still have concerns about their vaginal health. And then if they've answered yes to either of those questions, they move on to see if they have reported little or no interest in sex, decreased or loss of sensation, decreased vaginal lubrication, difficulty reaching orgasm, pain with sex, vaginal or vulvar pain or discomfort not during sex, or anxiety. So now, let's see, go on here. So hopefully this has given you many different ways to try in your clinic and see what sits well with you and what is easy to incorporate into your workflow. And hopefully make the commitment to ask your cancer patients about their sexual function, just as you would ask them about any other medical symptom. So now I'm going to move into talking about the domains of sexual dysfunction, including genital symptoms such as the genitourinary syndrome of menopause and pelvic floor dysfunction. Then we'll talk about sexual response, including desire, arousal, and orgasm, and then the psychosocial factors that can play in, including body image and relationship and intimacy issues. So first, the genitourinary syndrome of menopause. So this is a syndrome that's caused by the decrease in estrogen that comes with menopause. For our cancer patients, this can come about through essentially low estrogen caused by premature menopause from chemotherapy, or the effects of estrogen blockers, including tamoxifen and aromatase inhibitors, or through removal of the ovaries through various cancer surgeries. So genitourinary syndrome of menopause can cause dryness, decreased lubrication, discomfort or pain with sexual activity, bleeding, decreased arousal, orgasm, or desire, and then a burning or itching of the vulva or vagina. It can also cause dysuria or urinary frequency and urgency. And the diagram here shows some of the anatomic changes that come about with the genitourinary syndrome of menopause. And that actually includes narrowing of the vagina, shortening of the vagina, loss of the folds and the elasticity, and thinning of the vaginal walls. So I think, we are accustomed to hearing about vaginal dryness, vaginal atrophy, but actually the narrowing and shortening of the vagina is an associated symptom too. And there's loss of blood flow to the vagina. So the first step in treating our cancer patients who have GSM, genitourinary syndrome of menopause, are vaginal moisturizers and lubricants. And so this is a very good point for you to educate your patients on what are vaginal moisturizers and lubricants and how should they be used. So these are really two separate products that are used for separate purposes. So a vaginal moisturizer is used on a regular basis to maintain vaginal and vulvar moisture and the health of the tissue, regardless of sexual activity. And patients really need to use these vaginal moisturizers minimum 3 times a week, but up to 5 times a week or even daily in order for them to be effective. Vaginal lubricants are a different product that are used for a different purpose. And that purpose is to reduce friction and relieve discomfort with any type of sexual touch or with vaginal penetration. So there's a number of different vaginal moisturizers that can be recommended. Some of them are products that can be purchased either at the store or online, and other ones are natural moisturizers. So for example, coconut oil is a natural oil that's used for cooking and other things, comes in the form of a solid, and patients can use this. It will melt into an oil with just the warmth of the body temperature, and it can be applied externally. And this is this is one that patients are very receptive to and seem to like using. There's one note that because coconut oil may have natural antibacterial properties, one study has shown higher risk of candida colonization without infection. So I do counsel my patients if they get a yeast infection to discontinue use, but I haven't had any problems with that. Vitamin E capsules likewise can be used. The capsule can be broken open and the oil then applied to the vagina. These oils may stain undergarments, so patients should be counseled about that. And then in terms of moisturizers that can be purchased, it's important for patients to look for products that are glycerin-free and paraben-free, as these can be irritants, especially in the setting of dryness. And then a number of commercially available moisturizers actually contain hyaluronic acid, which can improve the effectiveness of that moisturizer. Vaginal lubricants, again, are used for sexual touch or vaginal penetration. And as a provider, it's important to know the different types of vaginal lubricants and when they should be used and when they shouldn't be used. So there's water-based, silicone-based, and oil-based. So the oil-based cannot be used with condoms because it can degrade the condoms. The silicone-based should not be used with silicone sex toys because it can damage the silicone. The silicone and the oil-based can stain the sheets where the water-based doesn't. In terms of the texture, the water-based ones can be sticky and are not as long-lasting as the silicone or the oil. And then water-based is not effective for use in water, but the silicone and the oil-based can be. So with this knowledge, patients can select which one makes the most sense for them to use. The vaginal pH is about 3.5 to 4, so the pH of a lubricant should be similar. Petroleum jelly and baby oil should not be used, and patients should avoid anything that has irritants in it, such as flavored, tingling, warming, glycerin, or having a lot of additives in it. So what about local hormones? So for non-cancer patients, local hormones are really the first-line treatment for this GSM, but there are some concerns in cancer patients, which I'm going to go over in detail in the next few slides. So local hormones come in a few different forms as creams, where conjugated estrogens have more variable absorption compared to other types. And the doses that are recommended for cancer patients are actually lower than the FDA approved doses. So we can use lower doses and still have benefit in our patients. There's also vaginal estrogen that come in very low doses as well. So 10 micrograms or as low as 4 micrograms. These products are used daily for 2 weeks and then twice a week following that. And then another product is an insert that can be changed every 90 days. So one concern with local hormones, especially in patients with hormone receptor positive breast cancer, is the theoretical possibility of hormones being absorbed into the bloodstream and contributing to cancer recurrence. So what do we know and what isn't true, and what is the data right now? So we do know that estrogen can be absorbed into the bloodstream with the use of topical hormone preparations. So this is showing that in some, but not in all patients, that hormone levels can increase. This is showing various different aromatase inhibitors, but then also raloxifene and tamoxifen. So the important thing to understand here with a little detail is that patients who have estrogen positive breast cancer can be treated either with a medication called an aromatase inhibitor or with tamoxifen. And aromatase inhibitors, they work by lowering the body's natural production of estrogen. So if there's any added estrogen into the system, the aromatase inhibitor won't lower that. Tamoxifen, on the other hand, works to block the effect of estrogen. So if there's a little extra estrogen added in the system, the tamoxifen, in theory, can still block that effect. So when we're talking about our patients with estrogen positive breast cancer on hormone blockers, it does matter if they're on an aromatase inhibitor or if they're on tamoxifen. So the big question is, are they safe? What do we know? So there are no randomized controlled trials that look at the safety of vaginal hormones in patients with breast cancer, specifically hormone receptor positive breast cancer on aromatase inhibitors. However, we do have information from a number of other studies that can inform our conversations with patients. So multiple studies that look at non-cancer patients have shown that women who use vaginal estrogen do not have an increased risk of de novo or of developing breast cancer. And then one study looked at patients who used local estrogen therapy who had breast cancer and did not see an increased risk of recurrence in women with breast cancer who used vaginal hormones. So how do we put this all together? Luckily, it's not on us to just put that together ourselves. Several national societies have issued guidelines and comments on this that we can use when we're discussing the use of vaginal estrogen in breast cancer with our patients. So ASCO comments on the use of vaginal estrogen and says that for women with hormone positive breast cancer who are symptomatic and not responding to conservative measures, low dose vaginal estrogen can be considered after a thorough discussion of the risks and benefits. And when I discuss with my patients, I go over essentially what we just talked about in the past few slides. We know there could be some absorption, and this is the information we have. We have not seen a higher risk of de novo breast cancer, and in limited data sets, we have not seen increased risk of recurrence, but we don't have a randomized controlled trial. The American College of Obstetrics and Gynecologists, ACOG, has also put out a committee opinion on this, the use of vaginal estrogen in women with a history of estrogen-dependent breast cancer. And they state that first-line non-hormonal approaches should be used. And with women who have estrogen-dependent breast cancer, vaginal estrogen should be reserved for those who are unresponsive to non-hormonal measures, and the decision to use vaginal estrogen may be made together with the patient's oncologist and should use informed decision-making and consent process. And then goes on to say that data do not show an increased risk of cancer recurrence among women currently undergoing treatment for breast cancer or those with a history of breast cancer who use vaginal estrogen. And then one final committee opinion or guideline consensus statement comes from the North American Menopause Society and the International Society for the Study of Women's Sexual Health. And they go over various different scenarios for patients who have breast cancer and go on to say women with estrogen positive breast cancer on aromatase inhibitor, those who have failed non-hormonal treatments may still be candidates for local hormone therapy after review with the woman's oncologist versus switch to tamoxifen. So how do we balance these risks? So certainly thinking about it, patients who have who are using tamoxifen, who have estrogen negative disease, who have a lower risk cancer, and who have more severe symptoms are those that one might be more likely to recommend the use of vaginal estrogen. Whereas those who are on an aromatase inhibitor, again, considering all the other factors, may consider switching to tamoxifen if you want to utilize vaginal estrogen or just relieve the incidence of it. Those who have ER positive disease or higher risk cancers would be part of that shared decision-making process. The clinical pearl here from Audrey is that vaginal hormones are not contraindicated in breast cancer, that this is something that can be utilized for our patients together with an informed risk-benefit discussion. So now I'm going to move on to our first anatomy lesson, the vestibule. So the vestibule is the area illustrated here prior to the vaginal opening. And this is an area that can actually be the source of pain with sex, and that's called insertional dyspareunia. So there is a study that looked at using topical lidocaine for insertional dyspareunia. So 46 postmenopausal breast cancer patients who had severe GSM were administered either self-administered 4% aqueous lidocaine versus saline for about 3 minutes before penetration, and this reduced dyspareunia or pain with sex from 88% to 33% with the use of saline. So this is something that is available for us to recommend and provide to patients 4% lidocaine. After they apply it and let it sit in, they can then wipe it off so that it doesn't affect their partner. So vibrators are also a tool that can be used for patients to improve their genital health. And so while you are all trying to figure out what goes where with these pictures, I'll comment that as a medical tool, the use of vibrators can increase blood flow to the vagina and therefore improve the health of the vaginal tissue. So as you recall, one of the changes that can happen in GSM is reduced blood flow. So vibrators can actually be used as a medical intervention that will increase blood flow and thereby increase the health of the tissue. So now I'm going to go on and talk about another domain of sexual dysfunction, which is pelvic floor dysfunction. And Audrey's clinical pearl here is that it is all about the pelvic floor. And I agree with her because I've had patients who I've had concern about pelvic floor dysfunction, sent them to a pelvic floor physical therapist. And when they come back and tell me that it no longer hurts to have sex, you realize it is just all about the pelvic floor. So what is the pelvic floor? So our anatomy lesson number 2 here shows that the pelvic floor consists of a group of muscles that help to lift and support the pelvic organ. So in women, this would include bladder, vagina, and rectum. And this can be a source of dysfunction. So one form of pelvic floor dysfunction is an underactive pelvic floor. And we think of this in terms of organ prolapse or incontinence, being told to do your Kegels. That is trying to remedy an underactive pelvic floor. But the issue that I find more of our patients may actually deal with is an overactive pelvic floor. And what happens in this case is that the pelvic floor, which is meant to be able to relax and contract naturally for proper functioning, may be chronically overactive and contracted. And that can cause a problem called pelvic pain syndrome, which can be vestibulodynia, so pain more on that outer aspect, or genitopelvic penetration pain disorder, which encompasses dyspareunia and vaginismus. And so women, patients may be actually walking around with an overactive pelvic floor and not even be aware of it. And it can cause significant problems in multiple areas. So not only pain with sex, but actually urinary urgency frequency, or even urinary retention, even constipation as a result of an overactive pelvic floor. So this is where a pelvic floor physical therapist comes in and can really just turn somebody's life around who's suffering from this problem. So what is pelvic floor physical therapy? So pelvic floor physical therapy is physical therapy that focuses on the pelvic floor. Patients to consider referring are those who have pain with penetration or incontinence or constipation. At the first visit, the therapist will take a history and do a musculoskeletal examination, focusing attention on the hip and the lumbar spine. And the reason for that is that the external muscles in the hip and the spine and others all contribute to the action of the pelvic floor and need to be considered as a whole. If it's appropriate, the therapist can do an internal exam as well and can identify trigger points or tender points in the pelvic floor musculature, as well as assess for the tone and the strength. So interventions can include actually manual therapy like stretching or something called trigger point release. Also teaching patients how to connect the pelvic floor and the breath, and using techniques like deep breathing and yoga poses, such as child's pose and happy baby can help as well. And then patients can actually be in charge of using tools to help to manage symptoms themselves at home. And some of these are a vaginal wand, which is kind of that squiggly thing. So this is a tool that has one aspect that can be inserted through the vagina and another one through the rectum to find trigger points on the pelvic floor to allow those to be released and the pain to be improved. Biofeedback is another technique that can be used. So vaginal dilators are a tool that can be used together with physical therapy that can help patients who have various problems, including vaginal stenosis, pain, pelvic floor dysfunction, or sequelae of pelvic radiation. And vaginal dilators can be given to patients in a kit that includes one starting as small as like their pinky finger and then going on to larger sizes. And the patient can use the graduated sizes to actually reduce or even prevent development of vaginal stenosis. And so this is something that is commonly prescribed to patients who undergo pelvic radiation more effective when it's given as a preventative measure. However, studies have shown that many women discontinue the use of vaginal dilators due to insufficient education or instruction on their use. So working together with a pelvic floor physical therapist to properly instruct and educate patients on the use of vaginal dilators is important. Another issue that can arise is what is known as vaginismus. And vaginismus is a penetration disorder where any attempted vaginal penetration, which could be a tampon, a finger, a dilator, a speculum for a medical exam, or intercourse, can be painful or even impossible. And there can be persistent and recurrent difficulties in penetration despite the plan to do so. And this can really trigger a cycle of fear, anxiety, and pain with the patient where they've had an experience of severe pain with penetration. And then in anticipation of penetration, they feel fear and anxiety. And that results in muscle clenching that will then cause more pain with penetration. And so some of these patients will describe that feeling as attempted intercourse feels like hitting a wall. And I've had patients where they're describing their symptoms to me and I ask them, does it feel like something is hitting a wall? And just that term really connects as if I've been able to put into words what they've been feeling, but haven't quite been able to articulate. And so this is a classic description of vaginismus. And so for treatment of vaginismus, physical therapy with or without biofeedback can be important, as well as the vaginal dilators can be used. But some patients may also actually benefit from psychotherapy or sex therapy and relationship counseling, where a therapist can take them through procedures to sort of exercise they do at home to help go through this, the dilator therapy. And then another intervention is actually injectable botulism toxin, which has been shown to reduce the symptoms of vaginismus. So now I'm going to move on from the genital symptoms to sexual response. So this really consists of desire, arousal, and orgasm. So we need to think of this in the context of the female sexual response cycle. So in the past, sexual response may have been considered as a more linear process, which starts with desire, then leads to arousal, and then leads to climax or orgasm. But Dr. Rosemary Basin in the year 2000 came up with this female sexual response cycle. And this is actually very important in kind of understanding what normal sexual response is. And the idea here is that for female sexuality, there's a transition from neutrality to arousal. And this is not a linear process, but a cyclical process. And so spontaneous sex drive can be one of the factors that leads to that switch from neutrality to arousal. However, it's not always like that. And it could actually be that arousal then leads to desire. And so I think this cycle was really a turning point for understanding that female sexual response is not a linear process. So sexual stimuli, which includes biological and psychological factors, can lead to arousal, as can the spontaneous sex drive. That then can lead to desire, emotional satisfaction, and then emotional intimacy. And so some patients who have changes in their spontaneous sex drive can feel reassured that having responsive desire is also a normal and a natural part of the female sexual response cycle. So according to ASCO, women with cancer who are experiencing problems in sexual response can benefit from psychosocial or psychosexual counseling. And also flibanserin may be offered to premenopausal women, which I'll talk about in a minute. So according to, this is just showing the prevalence of hypoactive sexual desire disorder in patients without cancer. And this is showing rates in those ages, 20 to 49 and then 50 to 70. And patients who undergo surgical menopause did have higher rates. And many of our patients with cancer may have undergone surgical menopause either through having a gynecological malignancy or having removal of the ovaries as part of breast cancer treatment. So what do we do to help a patient who's struggling with low desire? The first thing is to understand that desire is not magic. It is a biopsychosocial phenomenon. So on the biological standpoint, many neurotransmitters and hormones affect sexual function. So estrogen, melanocortins, dopamine are all excitatory towards this pathway, whereas other neurotransmitters, including serotonin, other factors like opioids, are inhibitory. So the first step is to look at the medications that a patient is on, because many of the medicines that we commonly prescribe to our cancer patients actually have negative impacts on desire. And that includes multiple psychotropic medications, including SSRIs, SNRIs, tricyclics, antipsychotics, and other drug classes, including chemo, aromatase inhibitors, H2 blockers, which we commonly give with chemotherapy, and opioids for treatment of cancer pain. So that's the first step to look at this. When looking at antidepressant medications, many of them can have impacts on desire, arousal, and orgasm. And looking at the relative frequencies, bupropion is one that has a lower incidence of causing sexual dysfunction. So in order to treat or educate patients, first is talking about the female and male, if that's applicable, sexual response and dysfunction, communicating, setting expectations, talking about how diet, exercise, and stress can impact sexual health. And then in medical terms, normalizing the use of fantasy, self-stimulation, which is masturbation, and talking about different types and techniques of orgasm, as well as making sure that patients and their partners are familiar with female anatomy. In terms of medications, there are now 2 medications that are approved for female hypoactive sexual desire disorder. One of them is flibanserin, which was initially designed as an antidepressant, but then now, after many years, was approved as a treatment for desire. So this is an agent that acts both on the serotonin receptors to activate the 5-HT1A, which increases desire, and to block the 5-HT2A, which inhibits. So it's a dual activator and or dual agonist antagonist that overall hopes to improve desire. So this is FDA approved for generalized HSDD in premenopausal women not caused by medical or psychiatric condition, relationship problems, or medication effects. The side effects here are hypotension and syncope, which are not exactly the symptoms you want to be when you're in the mood. So this can be exacerbated by alcohol. So if this medication is prescribed, patients need to be extensively counseled about the side effects and also advised not to use this together with alcohol. The second agent is called bremelanotide, which is a melanocortin receptor agonist. So that was one of the neurotransmitters that I showed in the diagram earlier. And this is different. So unlike flibanserin, which is a daily medication, bremelanotide is actually an injectable medication, which can just be used as needed. And so this is more of a date night medication, where flibanserin is more of a daily medication. Again, here, this medication, while FDA approved, does have some side effects, including nausea. And so if it's prescribed, a patient may need to take some medication to help deal with the nausea too. So moving on to arousal and orgasm, other components of sexual response. Non-therapists, so clinicians who are non-therapists, can discuss arousal and orgasm with the patient and just give permission, essentially, to practice and explore self-stimulation or masturbation in privacy, to know what the patient herself wants and to communicate that with her partner. When it comes to referring for more intensive therapy, a psychosocial counselor or a sex therapist can be very helpful, utilizing techniques of cognitive behavioral therapy, or an exercise called sensate focus, which takes a couple through a series of guided exercises to help with arousal and an orgasm, ultimately through a desensitization. So finally, in my last couple minutes here, I'm gonna touch on psychosocial aspects like body image and relationship. And so this is, body image is a common concern that cancer patients can have, not only after breast cancer, but many other cancer treatments alter the way that somebody may think about, perceive, and act upon issues related to one's body. So this is more than just physical appearance. And so patients who have body image concerns, we should be directly asking our patients about this and then referring for psychosocial counseling. So in order to help us address and, oops, I'm flipping through this really fast. Sorry about that. To address sexual health, we have made a change in, sorry, I'm not sure why it's going through this so fast, but we've made a change in the review of systems within EPIC so that female sexual health can specifically be documented here, so that those who use that as part of their routine encounters can formalize and track sexual health concerns. And then also an order set, we've developed an order set, which is available through EPIC, that goes through essentially what the ASCO recommendations are and how to address these various different domains as I've gone through. All right, do we have any questions? Thank you so much for your attention.
Awesome. We had some, that was a great talk, Dr. Agarwal. We'll have a couple quick questions. So for sake of time, are there any specific dietary recommendations you have for these types of patients beyond a well-balanced whole foods approach?
There's not. The type of diet that I would recommend would be a Mediterranean-based diet, which has been tied to having a better sexual health overall.
Okay, and then the next question is, can you comment on the use of DHEA, Asfena, testosterone in women with estrogen-positive breast cancer?
Yeah, so that's a great question. So DHEA, according to the ASCO guidelines, can be offered to patients as well. But again, in the FDA approval, it's written on there that this was not studied and should not be given in patients who have breast cancer. So just like the vaginal estrogen, there is no evidence that they increase the risk of recurrence in patients who have breast cancer. And then the other medications, so testosterone, at this time, I do not give that to patients who have breast cancer. And then other SERMs also have not been studied in patients who have cancer.
Another good question, do blood counts play a role in this conversation, especially low WBCs or low platelets? And should we ever counsel our patients to avoid sex while actively receiving chemotherapy?
Yeah, so that's a great question. So I think that for patients who are starting out on chemotherapy, there's a lot of issues related to sex that we need to be discussing right off the bat. First of all, is it safe to have sex during chemotherapy? And although penetrative intercourse should be avoided at times when the counts are expected to be at the lowest, at other times it does not have to be avoided, I counsel my patients to use barrier protection due to the possibility of bodily fluids potentially being contaminated. So I counsel my patients to use barrier, but do tell them that aside from at least the patients that I'm treating, aside from the few days when they have the lowest blood counts, they can proceed with it. And the other side of that is pregnancy prevention. So, be very clear with your patients that it is still possible potentially to get pregnant while you're on chemotherapy, but that would cause higher chances of miscarriage or even, death to the fetus while on chemotherapy. So they need to be using that contraception during chemotherapy. And so that needs to be part of the conversation up front.
And then just last, if I can just add, where do you see the team playing a role? Because I would say that, knowing how sometimes our team, maybe the nurse or an MA, has a more natural relationship with that person and they feel more comfortable. How should we work those folks in? And then the second piece is, since there was so much information there and a lot of that where we're not necessarily familiar by, as a system, what should we be doing so we have the right information, whether it was on some of the dilators or things like that? I don't know that many of us have that encyclopedic understanding of those types of things.
Yeah, so I think that the entire medical team is a critical, team player in addressing sexual health. And so many patients may feel perhaps more comfortable talking to the clinical nurse who they may know very well about sexual dysfunction. So I think within a team, it would be fully appropriate to designate a team member as the one who may initiate those conversations, one who knows what to ask and who has that level of comfort and who can communicate it. And so this can be the nurse navigator, the mid-level provider, the physician, the chemotherapy nurses. I mean, anybody on the team can ask the patient how their sexual health is. And then with the resources we've developed, can plug them in with the correct and appropriate responses. So if the patient's having a sexual concern and that's identified by the nurse, just let the doctor know and we can utilize this smart set. We can refer to a sexual health clinic as well for more intervention. So absolutely, the entire medical team is involved with this. And then what was the second question again?
It was more around you had so much information, but I think a lot of this, to be able to make everyone facile at explaining it and discussing it, some of them are very uncomfortable for people both to discuss, but also to hear. So what can we do as a system?
Yeah, so I think a patient who may benefit, so you're specifically asking about vaginal dilators. So a patient who's had pelvic radiation for a gynecological malignancy or a different malignancy that happens to be in the pelvis can be referred to a pelvic floor physical therapist for counseling and prescribing the dilators. And so that environment has the time and the setup and the education to be able to counsel the patient on the correct use and reinforce that it's being used correctly over time.
Great. And here's one last question. Any thoughts on Primrose? A lot of GYNs recommend even in breast cancer patients.
Right. So again, really limited on what we can say about Primrose, which may have some estrogen-like effects to it. I think one concern is always the amounts that are in the products that the patients are using. So I would proceed with caution there.
Great. So that was really wonderful. Let's finish off. If anyone has other questions, I'm certainly you can ask offline, and Dr. Agarwal, who is the expert, can help. I think this has been such an important topic and something we should continue the dialogue on for sure. We'll put the poll question beforehand, but let's go back to the poll question. Did this program increase your comfort level with discussing sexual health with your breast cancer patients? Vote early, vote often. There we go. Let's see here.
Oh, wonderful.
Yes, there you go.
That's great to see.
Great job. That is great. I mean, I found this fascinating and I learned a ton myself. And so as a reminder, you'll receive a link to an evaluation for credit. In addition to an email, when you exit this webinar, you will see a link to a SurveyMonkey. Select the continue button for the evaluation/credit. Just FYI, our next NCI educational program for providers will be a breast health update in June. Final date will be determined soon. Please check back at nortoncme.com for further details. I want to thank Dr. Agarwal. It was really a tremendous lecture, and I want to thank you all for joining us. And I hope everyone has a safe and healthy weekend and get your vaccine. Thank you.